afternoon, everyone, and welcome to the joint Honoring Choices Ariadne Labs webinar on More, Earlier, and Better Conversations to Improve Serious Illness Care. I'm Francine, and I'll be one of the presenters for this event. Thank you again for joining us today. Before we begin, I'll introduce our co-presenters today. So Ellen Diablo is the President and CEO of Honoring Choices Massachusetts. Ms. Diablo is an attorney with a concentration in guardianship law and health care planning. She is a member of the Department of Public Health Palliative Care and Quality of Life Interdisciplinary Advocacy Group and chairs the Healthcare Planning and MOLE Subcommittee. Ellen is a certified mediator and experienced advocate for the rights of adults with cognitive challenge. Dr. Rochelle Vern is an associate director of one of our serious illness care program and one of the palliative care faculty members at Ariadne Labs. She also co-led our flagship study at the Dana-Farber Care Institute. Before we dive in, I want to just go over some of the webinar functionality with you. So we will be keeping the phone lines on mute just to cut down on background noise. If you do have a question or comment at any point during the call, you can either type it into the chat box on the right-hand side of your screen or use the raise hand icon, and we'll call on you and you can say your question out loud. We will unmute your line. So you can, on this screen, you can see in the smaller circle, there's the raise the hand icon. It is on the right-hand side of the screen under the Participants tab, and then the chat box is also on the right-hand side. You might have to click on the top of the right-hand side. You should see a chat box that will probably open up for you. Again, if at any point you have any technical questions or concerns, please use the chat to host function, and either I or my colleague, Jim, will assist you directly. Again, we're just very excited to be co-hosting this webinar today with Honoring Choices. So today's objectives really are to offer interdisciplinary colleagues a structured approach to care planning discussions that begin at 18 years old and continue through adulthood. We'll also provide you a roadmap of the types of advanced care planning discussions on the healthcare journey that outlines who, when, and how to have these conversations. And finally, we'll describe a structured, evidence-based approach for patient-clinician conversations about values, goals, and choices for patients with serious illness. I'm now going to hand it over to our colleague, Ellen, from Honoring Choices, who's going to go through the beginning part of this webinar.
Thank you, Francine. It's a pleasure to be here with everyone today. I hope everyone can hear me well. So at Honoring Choices Massachusetts, we believe that sorry? We're all good. Okay, we believe that everyone's on a healthcare journey to get the best possible care at every phase of health. And that includes promoting everyday wellness, managing that health as we age, and living with serious illness. At Honoring Choices, our mission is to inform and empower adults, everyone who's 18 and older, to make a healthcare plan and then to connect to quality person-centered care right in their community and all through their lifetime. And we think everybody needs a plan. You know, your plan is your roadmap for that person-directed care. We know that healthcare is not a straight line. It's really this dynamic, flowing, and changing process. And having a roadmap that can help generate early and ongoing, meaningful discussions really helps protect you and your right to get the care that you want, even if you have just had a minor injury and you're expected to recover. It certainly helps your family to know how to best care for you, and it helps our care providers align care to our patients' goals and values and choices. So at Honoring Choices, we're really offering a structured approach to healthcare planning. For us, you notice I'm not using the word advanced care planning because it really is more encompassing for us, that healthcare planning is this process that includes both this everyday care planning and advanced care planning. And we offer a 3-step planning guide. It's a step-by-step process. And in step 1, what we encourage consumers to do is, before we even go to a planning document, to take a moment to think about where you are on this healthcare journey and what kind of information you need to make choices. And once we have some of those choices, we go to step 2, to the plan piece, where we're talking to our family and people who are important to us. And we're writing down our choices in the 5 Massachusetts planning documents. And then we go over to step 3. The important piece is to really connect, to put this plan into action, to honor choices all through our lifetime. And we're talking to consumers about starting with that question, how are you feeling today? Here's how I'm feeling today. To really talk about your current care and current care goals, and also what's ahead for you. So what we're offering is the same language and the same tools to both consumers and to care providers. And we're finding this is really allowing folks to have effective discussions, that our tools are all based in Massachusetts law, which is this great equalizer to start to unify our language and develop a common consumer-friendly language and set of Massachusetts tools. So all the Honoring Choices partners, who are now hundreds of these wonderful healthcare providers and community professionals around the state, are using the same common language and incorporating it right into their programs. Our signature program is the Who's Your Agent program, because what we believe certainly is that that's a great beginning, that everyone has the right to make a plan and to direct their care. And one of our first choices is choosing an agent. And we can do that in the Getting Started Toolkit. That helps us make a plan. And in that toolkit, we simply are choosing an agent in a healthcare proxy. We're telling our agent what we want in a personal directive, and we're starting to talk to our care providers using our discussion guides. And then after that, we have hopefully a whole lifetime in front of us, and that's where the Next Steps toolkits come in to talk about care through our lifetime. I just want to mention the Getting Started Toolkit. I'm often asked, where do we start these discussions? Well, I would encourage everyone to start right here. Start with the Getting Started Toolkit. In Massachusetts, the law is really wonderful. It talks about the healthcare agent as the person and the proxy as the document, which makes this kind of welcoming to talk to people, to say, not do you have a proxy, but do you have an agent? Is there a person who can be your advocate? So we do the healthcare proxy. We have it translated into 9 languages. And then once you do that, you can tell your agent what you want for care and write that down in a personal directive. Our personal directive is just a personal document where you write down what's important to you and what you want for care. What's been terrific about this document is when people say, you know, I don't have an agent, I just don't have anyone to appoint. Our next statement is, it's no agent, no problem. Here's where you start your healthcare plan, right with this personal directive. And we as advocates can help people write down and think about what they want for care. And then we go to step 3, of course, which is to talk to our providers about that plan. Working with Ariadne Labs today is such a thrill and honor for us, because one of the things I'm very impressed with the Serious Illness Conversation Guide is that it's really wonderful consumer-based guide. And it really lends to the flow of the Honoring Choices tools as well, to build these effective discussions right through our lifetime. So today we're going to look at some key questions around this structured approach, which is, what do you want to talk about? What do you talk about and when? How do you start these discussions? And once you start making decisions, how do you write them down in the Massachusetts planning documents? And who can have these discussions? So we're going to offer you, for the first time here, a healthcare planning roadmap. So this is a bit comprehensive, and just follow me through, and then we'll look at each of the phases together. But in the roadmap, we see people on a journey. We see the 3 phases of health. We're using this a lot in the Honoring Choices tools, and we're finding consumers really like to look at the phases to locate where they are in the journey or where one of their loved ones is on the journey. And if you look at the gray left column, those are the choices we're talking about. Those are the key questions today. So what to talk about? If you read across, you're seeing topics about everyday care goals and advanced care planning questions. If you jump down to the next gray box, talking about starting this discussion and how do we do that, if you read across, you'll actually see a series of discussion guides. They're all made to build on one another so that you have great effective tools right throughout someone's lifetime. And if we go down one more level, when we start these discussions, we start making choices, we can write them down. There you see the 5 Massachusetts planning documents. They're put into 2 toolkits, the Getting Started Kit and the Next Steps Kit. So if we just drill down a little bit into the Promoting Everyday Wellness, this is a big focus for Honoring Choices, to try to start the habit, if you will, of routine known conversations right early in life, between 18 and 45. We're not only starting those conversations, but we're engaging people in that proactive and preventative care. And to do that, you can use the Everyday Care Guide to start those discussions. And then we'll write it down. We start to write it down in that Getting Started Toolkit. And if we move over to the chronic illness phase, or the focus here is really living well as we age and managing chronic illness and quality of life. When we talk to consumers, this is the area that we find most concern, where consumers have the most questions about what is their medical condition, what are their treatment options, and what's ahead for them. Often their biggest question is, what information do I need to be able to make choices about my care? And you can start that discussion with the Managing the Health and Chronic Illness Discussion Guide, and write it down again in the medical record and starting to use the Next Steps Toolkit. If you work with seniors, you know that money is a primary concern. As I talk to seniors, they're very happy to have the Getting Started Toolkit, but they often say to me, okay, now let's talk about money, because they're concerned about how to pay for care. What happens if they become disabled? Who's going to take care of their financial matters? That all can be helped with a durable power of attorney. And if you're not doing that as a care provider, that's fine. There's information up on our website, and some of our community partners can help out with that. So that brings us to that last phase in serious illness. And what we're seeing with consumers, again, is this, it gets very confusing, and as you know, it gets very worrisome. So our partners started to focus on, well, what do we really need to know at first diagnosis? When somebody's first diagnosed, what would we want them to know to be able to do more person-directed care? And what we're finding that is if they haven't had many conversations or any conversations, to just go ahead and go back to that Getting Started Toolkit. A lot of our hospice partners use it in that way because they find people haven't had any conversations, and this gives the family and the person some degree of control and empowerment about their own choices. And as we read down, palliative care is a big topic. We're working with a lot of our partners on how to introduce that. And again, first diagnosis would be a great point of information for a consumer. What is palliative care? How does it help me with pain, the pain, symptoms, and stress of living with serious illness? And what's the difference between that and hospice care? We have a great discussion guide for you to help you open up that conversation. And as you see, quite a few discussion guides for that period of life. And in terms of adding documents to the plan, that's where we're adding the most, and the CCD&R, which we'll talk about a little bit more. So this is where we write down what we want, and we continually add and revise as our choices change over time. And I think it's a very exciting time in Massachusetts right now for serious illness. Of note, the Massachusetts Coalition for Serious Illness Care is doing an incredible job of coordinating all the wonderful work in the state, trying to promote some systematic change in care. And the last piece, then, is who can have these conversations. Well, at Honoring Choices, it's everybody. It's all of our care providers. Anyone can really engage people in these first conversations using the Getting Started Toolkit. Our partners have started over 30,000 new conversations to date. And one of the things they've noticed is that it really is fostering a team approach, because everyone has the same language and the same tools. So each knows their role, each can figure out the value they can add starting to start these conversations and build on these conversations, they're finding that caregivers and families can easily come into the process too and be part of this plan. As one of our palliative care doctors said, she was always excited to use these tools with her team because she got to do her part, the diagnosis and the prognosis, and she encouraged her patients to go and talk to everyone else. And the team in that way learned a lot more about the patient, and the patient and the family really developed this deeper trust and comfort level. So that brings us to the serious illness part of this discussion and how you start that, and I'm going to pass this right back to Francine.
Great. Thank you, Ellen, so much for that great overview of the Honoring Choices portion. So here at Ariadne Labs, this is where we are in our office setting. We are a joint innovation center, and one of our programs is the Serious Illness Care Program, in addition to a few others, including one in birth and one in surgery. But our mission for the Serious Illness Care Program is to improve the lives of all people with serious illness by increasing meaningful conversations with their clinicians about their values and priorities. So you really can see how it fits into that last stage of the roadmap in the Honoring Choices framework. And it really, before we get in more to the details of the conversation guide, we just wanted to take a step back about the why this came about and why we created this program. We know that early conversations about patients' values and goals are linked to better serious illness care. There's increased goal concordant care when patients do have these early conversations, which also improve the quality of life and patient well-being. Further studies have shown that patients have fewer hospitalizations, and it improves or leads to more and earlier hospice care. And finally, in addition to the patient side of it, further studies have shown that there are better patient and family coping when there are earlier conversations about patients' values and goals. The problem is there's failure to recognize and honor patients' values and goals, and these are associated with harm. So poor quality of life and unnecessary physical, emotional suffering for patients. This can lead to family distress. Oftentimes there's poor alignment of medical care with patient wishes. Instead of sort of leading to hospice care, this can often lead to prolonged and undesirable hospitalization and ICU stays, which has a negative side effect of distress among clinical staff. So what does this all sum into, which is really conversations are infrequent, late, and limited. So there's fewer than a third of patients with end-stage diagnosis report end-of-life discussions with clinicians. So they're late in the disease trajectory or in relation to death. Patients with advanced cancer, on average, their first end-of-life discussion is 33 days before death. And 55% of these end-of-life discussions occurred in the hospital. And finally, these conversations are limited in their quality. So they fail to address key elements of quality discussions. And then what we often, or another key aspect of our program is about documentation of these conversations. We've seen over and the evidence shows that they're not well documented, and this really is a concern for patient safety. When they do take place, again, they're not documented. They're often not documented accurately, and they're not in a necessarily easily retrievable place in the electronic medical record. Here in our team, we often refer to this as the allergy analogy, meaning that conversations and outcomes of these conversations should be in an easily retrievable place, such as allergy information is, so that patients' values and goals are known to all care providers at any point in their medical care. I'm going to hand it to Rochelle, who's going to talk more about the harm caused, but also about the pieces of the conversation guide.
Yeah, hi, thanks Francine and Ellen, and I'm delighted to be here with you all today. Let's talk about two different types of harm. So first, the not knowing what people want, it really can lead to patients getting care that's unwanted, and so that's really what we're trying to avoid here. So I think that there's really increased national focus to improve communication about values and goals. And I think, you know, as I reflect on the training that I received about these conversations, they really focused solely on what kind of procedures people would want, rather than what patients and families, what their values are. Patients really expect their clinicians to bring this up and to start the conversation. I was just at the International Advanced Care Planning meeting in Banff this past week, and I think it's really important how clinicians set up this conversation and give the rationale behind why this is so important. I also was just looking at how much the new billing codes are being used that were introduced in 2016 by CMS, and they've actually exceeded expectations. I think there's been about 35 million billed in the first year, and they just released new data that I haven't gotten a chance to look at yet. So how can we do better? I think our goal here is to set a new standard that everyone has access to high-quality, patient-centered conversations about serious illness, that every patient, every time will have a high-quality conversation that gets at what really matters to them, and that we are, you know, that this message is consistent across patients and families, but also across the system with clinicians and healthcare leaders. I think clinicians really have a critical role in improving patient care by improving the conversations. One key element of our program is to systematically identify patients with serious illness who would benefit from conversations. You know, we started this program by using the surprise question. It misses up to 80% of patients who die. We're trying to find better ways to do this through machine learning, through algorithms, through risk stratification, to really get a better, more comprehensive way to identify those patients. Then we want to initiate the conversation. Like I said, the setup is really important. And then document them in a place where everyone can find the information, and that everyone, including physicians, nurse practitioners, nurses, social workers, can document in one place so that it's that you're not hunting through the record to find this very important information. Then creating a care plan in collaboration with the patient and the interdisciplinary team so that the care matches the goal. That's often with a recommendation from the clinician. And then we also can provide an example of high-quality communication for our colleagues and our students as well. Our program includes tools, training, and systems change. The tools include, as you can see, the Serious Illness Conversation Guide, the Clinician Reference Guide, which has a lot of scripting for particular situations. We also have a one-page patient preparation material, which goes through things like you may want to bring your family to this meeting. It's important to think about what matters to you most. And then the Family Communication Guide, which walks the patient through how to bring up difficult conversations with their family members. The training includes a 2.5-hour to 3-hour training session, and then the system change where we spend most of our time really is to try to change our systems, especially if you work in a large healthcare system. Changing these things can be pretty challenging. I talked about patient identification and how challenging that is. The reminder system, clinicians really are being asked to do so much these days, particularly primary care clinicians, and so having a way to remind people who needs to have these conversations and have it really be right in front of people so that it's easy to do the right thing. Then they use a conversation. Then they do the conversation using the guide after their training. The training entails didactic portion, a portion of demonstrating the guide and debriefing afterwards, and then individual practice using the guide and a trained medical actor and a facilitator. Then, as I said, we're working towards uniform documentation within the EMR and then patient and family support. We define a serious illness conversation as a conversation that focuses on values and goals and care preferences, offers an honest prognosis. That prognosis can be a time-based prognosis, or it can be a function-based prognosis, and we give that prognosis based on the patient preferences. We aim for these conversations to start early in the course of serious illness. That's 1 to 2. We think of serious illness as being the last 1 to 2 years of life, but it could be earlier, especially for a patient, say, with dementia. That might be much, much earlier than that. And we hope that this conversation provides the foundations, really, for making decisions in the future, and that these conversations are not a one and done, but that they should be iterative conversation and that they should be reviewed over time. So why use a guide or a checklist? Well, you know, I just flew this past weekend to Banff, and it was very smoky there. And, you know, I was very happy, you know, you're very happy that your pilot has a checklist to make sure that they're doing all the things that they're supposed to do. It also achieves a higher level of baseline performance. So you know, if everyone's following the same protocol, then you're not missing any steps. And they use these during complex and stressful situations. Certainly landing an airplane is that, and having a conversation with someone who's seriously ill is also that as well, and we're trying to prevent a crash. So this is our Serious Illness Conversation Guide. It's available on the Ariadne Labs website. And you can see on the left-hand side are the basic steps of the conversation: setting it up, assessing the patient's illness understanding, sharing our prognosis, exploring key topics, and then closing the conversation. And on the right-hand side are actual scripted questions to ask the patient. So like I said, I think the setup is really, really important. So you want to first introduce the idea. I'd like to talk to you about what's ahead with your illness and do some thinking in advance so that we can make sure we provide you with the care that you want. And then ask permission. Is this okay? We also need to provide, you know, engaging in this kind of conversation for a patient with serious illness is not to be taken lightheartedly. You know, you have to give patients a reason to do this. So they want to talk about what matters to you most so that you can provide that care that you want and that you can support family if they ever have to make decisions for them. Assess illness understanding information preferences. So what is your understanding now of where you are with your illness? That's really trying to assess how much the patient understands about their prognosis. And then how much information about what is likely to be ahead would you like from me? That question is specifically there to titrate your prognostic information. Sometimes I follow that up with something like, some patients like to know about time, some other patients like to know what to expect, others like to know about both. What kind of person are you? Some patients will say time, well, you know, only God knows that. Those patients are not really inviting a time-based prognosis. Other people will say something along the lines of, I'm more general, just kind of give it to me as to what to expect. On the flip side of that, some people will say, well, how long do I really have? And for those patients, it's really important to be very direct and answer as honestly as you can and not hedge. So here you can see some examples of language. Wish-worry framework is really important here. I wish we were not in this situation, but I'm worried that time might be as short as months to a year, for example. We always try to give a range of time. A functional prognosis. I hope that this is not the case, but I think this might be as strong as you will feel and that things are likely to get more difficult. Just a note, I think time-based prognoses, most physicians are most likely to give a time-based prognosis, and physicians may not feel that comfortable with time-based prognoses. For functional prognoses, I've worked with nurses and even some social workers that feel very comfortable with giving this kind of statement, and I think it is a form of prognostic disclosure. Unpredictable prognoses. It can be difficult to predict what will happen with your illness. I hope you continue to live well for a long time, but I'm worried that you could get sick quickly, and I think it's important to prepare for this. We often talk about using a plan B. So we're hoping for the best, but preparing for the worst. Following giving your prognosis, you want to always allow silence. Patients really need time to process their emotions. If you're noting that a patient is very upset, you can say something like, you seem upset, tell me more about what you're feeling. If it seems really like a surprise, you can note that, tell me more about what you're expecting to hear, or just noting how difficult it is. It's really hard to hear, tell me what you're thinking. Following that, we explore goals. I think the guide is really psychologically driven. So that the order of the questions is very important. Hearing someone's prognosis maybe short can be very challenging. So asking about goals right immediately after that is purposeful. So what are your most important goals if your health situation worsens? And then the flip side of that, what are your biggest fears and worries about the future with your health? We added this question, what gives you strength as you think about the future with your illness, after doing some focus groups in rural South Carolina with African American patients. And it's often a place where patients can talk about their religion or spirituality and as well as family. These questions are questions that I often found to be the least popular with clinicians, but are really incredibly important because of the difficulty of assessing values. I think it's really hard for clinicians to know how to assess values, and I think that's where these questions really shine. What abilities are so critical to your life that you can't imagine living without them? And if you become sicker, how much are you willing to go through for the possibility of gaining more time? The first question is really trying to look at function. The second question is looking at what people are willing to trade off. And then finally, how much does your family know about your priorities and wishes? Then closing the conversation, it's really important to repeat what you've heard. So to whatever the patient has told you, I've heard you say that your family is really important to you, or I hope that I understand that staying at home is really crucial. Then really offering a recommendation. Keeping that in mind and what we know about your illness, I recommend this. And it might be as simple as recommending another conversation, or it could be as complex as recommending hospice. It could be anything in between there. This will make us sure that your treatment plan reflects what's important to you, and then checking in. You'll note that many times in the guide, there's several times to check in with the patient. How does this plan seem to you? And then affirming commitment. This is the one time in the guide where I think you can use your own words. I think saying something to the effect of, I will do everything to help you through this, but you just want to make sure that you're not abandoning that patient, and using whatever words that feel genuine to you, I think, are best. Then you have to document it in the medical record, and we want to make sure that this communication is passed along between clinicians and between settings as well. So we've done research both in oncology and in high-risk primary care. And we just published our paper in high-risk primary care in Health Affairs in July, where we showed that the program led to more and better conversations. So if you're interested, you can look for that. And we also, I think, have a link to it on our website. So our goal is to really have better population health, that we have high quality of care for all of our patients, and that we have better training for all clinicians to have these conversations, and that the system really supports clinicians in doing the right thing. We found that patients in our Dana-Farber trial had reduced anxiety and depression. after having these conversations. And we're now currently looking at whether utilization is different between groups in those trials. And we're still also looking at clinician satisfaction. So we invite you to join our community of practice. It's free to join. You'll have access to our videos, webinars, the guide and tools, and the discussion forum. We have people from across the country and Canada as well as across the world that are part of this and who are implementing in those places and really learning a lot about that implementation. Take a look at the guide and see what you think of it and try it maybe with a patient or two and have a conversation with a colleague and let them know how it goes. And then we'd be delighted if you join us again for our other webinars about the program. This walks you through how to join the community of practice. It's a two-step process. You first go to Ariadne Labs, and then you'll get an email to authenticate your account.
Yeah, so you go to the community portal.ariadnelabs.org, and you create a community account, and then you'll go back and you'll request access for the serious illness community. And this is because we've really purposely made this community a private community, one in which people who are looking to either improve their own conversations or implement the serious illness care program are part of this community, and instead of having maybe patients or people interested in the media be part of this community. So we will review your profile, I'll accept you, and then you'll be part of the community. As Rochelle mentioned, there's lots of, I'm going to leave this up for a second, there's lots of resources on there. There's also rationale behind the development of the guide. We give a modifiable version of the guide, but first it walks you through the rationale of the guide itself and through each question. But we do encourage you to, put your logo on it, change the colors if you want, really make it your own for your setting so that it feels like another tool that you use every day in your home institution. So we're going to hand it back over to Ellen, who's going to then describe again how it fits with the toolkit and the next steps that you could take after the conversation.
Great. Thank you for Francine and Dr. Bernanke. That is really wonderful explanation, and I just love how consumer-based in many ways those questions are and the strategies you offer that really help focus that conversation on that person-directed care. So I just want to pick up with the Next Steps Toolkit here, which I think complements very well the Serious Illness Conversation Guide. Here is, again, we have people building on the Getting Started kit, and now we're just building on discussions, and we're adding to our plans, and we're revising our plans. So if we look just at this slide, we'll see that one of the tools we have for you that's pretty practical are the 5 Things to Talk About with Your Patients and Clients series. So this is actually 4 discussion guides. These are 3. The first one is the everyday care, and then the discussion guides really build to managing chronic illness, to living with serious illness, and one specifically on palliative care. There are 2 sets of guides here, one just for the consumer, one just for the care provider, but the questions are identical. They mirror each other. So what our care providers are doing are actually giving this out ahead of time. They're putting it in their waiting rooms. They're putting it in their admissions packets to try to have this conversation be more known and honored. And finally, I think, here, what I often get asked is the question is, isn't there just one group of tools that I can use for every patient? Because there are so many tools you can use. And I think there may not be one, but I think you might find in the discussion guides you saw today with the Serious Illness Care Conversation Guide and these, you'll see a flow. You'll see a continuous use that gives you a solid foundation for early and high-quality, effective discussions. So all those guides are right on the Honoring Choices website. They're all free and downloadable for you. And then the last piece, of course, is we go back to that healthcare plan itself. And if one of your clients or patients has a healthcare proxy and a personal directive, these are the the next 3 documents in Massachusetts that you can use: the Durable Power of Attorney, Medical Orders for Life-Sustaining Treatment, or the MOLS form, and the Comfort Care Do Not Resuscitate Order, or the CCDNR. And these are, we have information about all these tools on our website. We recommend the Durable Power is done with an attorney, and of course the other 2 documents are medical orders to do with a clinician. But we are encouraging folks to be very well informed about this, and everything, again, is there for you and downloadable. Just a word about MOLST. Honoring Choices is working through the state at this point to host MOLST workshops, to open up a dialogue across all the care providers to say, how do we do this together? How do we best craft a MOLST process that is highly responsive to the changing needs and choices of individuals, and that consistently delivers that person-centered care all through that serious illness journey. So we'd love your voice and your opinion on that. You can go to the website and see all of the work that's being done on MOLST. And please feel free to take a look at the website. As I said, all the tools are free and downloadable. We encourage you to come and join us. Come be a partner. It's free, and we are so fortunate to have the expertise of our partners to really direct the Honoring Choices mission, and everyone is welcome. Thank you. I'll pass this right back to Francine.
Great, thank you, Ellen. So we have about 10 more minutes, and we can open it up to questions, or if Jim, I don't know if we've received any questions. Yeah, we have a question already for Ellen or Rochelle. You can either raise your hand, again, that's in the, on the right-hand side of the screen under the panelist tab, there should be a raise the hand. You can also chat either the panelists or the host your question, and we can ask it live. Jim, do you want to answer the question?
Sure.
Rochelle?
Yeah. So the question is, what information is being directed to healthcare consumers? Physicians can open the conversation, lawyers can open the conversation, but we'd love to see demand from the patient-consumer side.
Well, maybe I'll answer that from our point of view. You know, Honoring Choices is built on a consumer-focused model. So everything that we've done orients from a consumer point of view. So all our documents are built that way to be do-it-yourself toolkits, to be informational toolkits. In our 3-step planning guide, that very first step on Explore, we are so fortunate to have Massachusetts doctors and clinicians and leaders actually donate or contribute question and answer articles on a whole diversity of topics so people can become more informed. So I think there's a lot for consumers. I spend a lot of time in the state just talking to consumers of different ages, and they're liking the toolkits. They're feeling more empowered by them, and the discussion guides actually they're bringing right to their doctor's appointment and saying, let's talk about this. Let's talk about my care. So I think we're starting to see a real empowered group of Massachusetts consumers.
Thanks, Ellen. One follow-up question to that. She's referring to how the word is getting out to patients, and know that they're patient-centric, but wondering if there are public service announcements that are getting the word out, or other ways of getting it out there.
I can just step in, but why don't you go ahead? Is that, Dr. Benecki, is that?
You know, I think as, you know, with the Affordable Care Act, I think there's just a lot more discussion of healthcare, and I think when I guess from a clinician standpoint, I always think of it as patient-centered rather than consumer-driven. I don't really, I guess I get a little confused about those terms, but I certainly think that from the patient standpoint, I think something like the Conversation Project that Ellen Goodman is leading is really trying to get word out to patients and families to talk about these things. You know, we are really, you know, our concern at Ariadne Lab is really to make sure that clinicians have the tools and training to be able to absorb if a patient comes and says, you know, I really want to talk about this. Some clinicians might not really even know where to start, and what we're really trying to do is to be able to give them a framework and a structure to do that.
Thanks, Rochelle. Here's another question from Paula Griswold. Often discussions that are emotionally charged, people don't often have their thoughts clearly defined and articulated in a first conversation. Are there recommendations about returning to the serious illness conversation over several discussions?
Absolutely. So when we first started this, we really expected clinicians to do this over many different visits. But what we found just in our research, at least in both oncology and in primary care, is that most clinicians would set aside about 20 minutes, about 18 minutes in oncology, 22 minutes in primary care to have the whole conversation. And I was a little surprised about this. I think what opening up this conversation does is that it leads to many more conversations and much more discussion of this. It sort of opens up the lines of communication.
And Rochelle briefly went over the systems change components as well. And what we have found as well is the patient preparation piece often helps the patient in that. And it doesn't have to be complex in any way. It's sort of making patients aware that maybe at the next visit, we're going to have a different type of visit. And I really want to have a conversation about you, about your values and goals, or what's most important to you. So when they come into that appointment, maybe the day or two or the week before, they're really thinking about these things. Because as you said, if you sort of catch a patient off guard, it can be emotionally charged, and they might not have all of their thoughts aligned or in order. And so that patient preparation piece, we have used handouts, which is a one-page handout that doesn't give any prognostic information, just that we're going to have a conversation at our next visit. And we found that that alone really lets patients sort of prepare just enough for the visit to get the information out that they need.
We've had somebody raise their hand. Joanna, I unmuted your line. Are you there?
Yes. Can you hear me?
Yes, you're live.
Okay, great, thanks. I imagine this is on the Ariadne website, but I just wondered if someone can briefly speak to how clinicians get to, like, how can doctors get to Ariadne Labs to do the training? Is it one by one, or, yeah?
How they get to the training?
Yeah, how can they get?
Yeah.
Yeah, so right now, we currently are working with systems to incorporate the whole program, including the identification piece, the documentation piece, and we didn't talk a lot about this, but we also, following the training, we provide coaching to clinicians about how to have conversations. So we are currently offering, in a pilot phase, are inviting institutions to join us in learning more about how this program works. And so we're in the first year of that. We hope that after this first year that we will be able to expand it more widely. In the past, we've run a couple of continuing medical education courses, and we may run those in the future as well. But currently, it's by institution. If people are interested more, I really encourage you to come to the webinars on our Community of Practice site.
Okay, great. And can it be out of state, out of Massachusetts? It's the last piece.
Yep. Yes, absolutely. Yes.
Global, actually.
All right, thank you.
Yes. Thank you.
Are there any other questions? Please use the chat function again, or raise your hand just like Joanna did. And thank you to those who have shared some comments. We appreciate those, and we'll share with others. I see Jody, you have your hand risen. Jody, are you there?
Yes, can you hear me?
Yes, we can.
So I'm Director of Palliative Care for a large geriatric care organization, and we've been interested in the Serious Illness Conversation Guide for a couple of years, really gaining a lot of momentum here. We're now poised to train our physicians, nurses, and other care providers throughout our system, but we need to train the trainers. I've got about 8 folks who would really like to get the training, and I'm wondering how to go about doing that. We're raring to go.
You and I both. We're working on that right now. We've had so much demand for doing this training that we haven't been able to keep up with it. So in the end of October, we're beginning a pilot of about 25 trainers, and I'm working on the curriculum right now. So we don't really have anything to share as of yet. I think it's really important to have very high quality training. What I would encourage is to just keep it very small to start with. Just start with a couple people and see how it goes, and then iterate. We hope to have more information, and may even be considering having a Train the Trainer course. In probably at this point, it would be the earliest would be the fall of 2018 or 2019 is more likely. But we are working on the same thing right now. What's that?
If we don't want to wait a year and a half to do this, I mean, we're fairly well equipped. I have a sophisticated palliative care program here, but it would be so great to have some training in this particular tool because it's unique, and but it sounds like it's hard to get that right now. Is that right?
Yeah, so I would say to join the webinars, and there is I think that would be the best recommendation as of right now.
Okay, thank you.
There's also on the Community of Practice website for geriatrics and nursing homes, there is a lovely adaptation by Charlie Chen, who's at University of British Columbia, where he adapted the guide, and I posted his poster on our Community of Practice website where he adapted it for use with surrogates, and I think it's a really nice example of he was very thoughtful about it. We have a document called Principles of Adaptation of Using the Guide, which walks you through, we ask, the guide is copyrighted, and we have instructions about how to use that copyright. And also, if you're going to change the guide, we have some sort of some instructions on the website that will tell you how to do that. And I think Charlie did a lovely job of, adapting the guide for that population.
That will be invaluable for us. Thank you for that reference.
We probably have time for one more question, and this I think is a follow-on to a question from earlier, but does it sometimes frighten or worry the patients when you give them a handout that says, we'll be talking about your goals at our next visit?
So we used the handout in oncology, and we did not have we had a lot of pushback from the clinicians about that fear. From the patients, talking about their values and goals is not frightening. Some of the patients did equate looking at that and thinking about end of life, but for the majority, most of them did not. For most part, the language is intentionally a little bit vague. And that handout in and of itself is not meant to give any prognostic information.
Yeah, we did a similar thing actually in the UK when implementing, and the patients actually were very grateful that they were going to have a conversation about their values and goals, and none of them were frightened by it. They were just grateful that a physician would spend that time, clinic appointment time, to discuss that. So, but again, the clinicians were more worried about that than the patients were. So we really want to thank you all again for joining us today. This webinar was recorded, so we can make it available to you all along with the slides. We will figure out the best way to get it to you, whether that be on the Honoring Choices platform or the Community Practice platform. But again, I would really just like to thank Ellen and Rochelle for this joint effort. It's really great to see the community of Massachusetts. I don't think we mentioned this, but everyone invited to this webinar today was solely from Massachusetts, and we really had a great turnout considering that's who was invited. So thank you all again. Please feel free to continue to send your questions. Join the community. We can continue sort of a Massachusetts cohort as we figure out the best way to improve serious illness care for the residents of Massachusetts. So thank you again. I hope you all have a wonderful afternoon.
Thank you so much. It was a pleasure to be with you.